Good afternoon, everyone. Welcome to our webinar. Thank you so much for spending some time with us this afternoon. The Prostate Cancer Foundation is delighted to host this webinar during National Military Appreciation Month. My name is Becky Campbell, and I am the manager of medical content here at PCF. I'd also like to thank our panelists at the outset who are so generously sharing their experience and expertise with us today. May is National Military Appreciation Month, a time when we honor all that veterans have given for our country. What you may not know is that prostate cancer is the most commonly diagnosed cancer in the VA system, with more than 500,000 veterans living with the disease. This May, PCF aims to bring need-to-know information to all men with prostate cancer with a special focus on veterans. Our distinguished panelists today are PCF physicians and researchers working in both the VA and in academic medical centers. They can speak to issues relevant to all patients, but also with a lens towards caring for those who have served our country. We would also like to thank our sponsor, AstraZeneca, for making this event possible. I'd like to briefly introduce you to the Prostate Cancer Foundation in case you are not familiar with our organization. PCF funds the world's most promising research to improve the detection, prevention, and treatment of prostate cancer and ultimately cure it for good. You can see the details on the slide about our scope, as well as some of the examples of the work that we funded. We also produce educational materials, including a comprehensive patient guide updated in 2021, a wellness guide, as well as many blogs and articles available on our website at pcf.org. Just a few housekeeping items before we dive in. So the webinar is being recorded and a link will be sent to all registered participants within a few days. Attendees will be muted throughout, but at the end we will have a Q&A session. You can type your question using the Q&A icon at the bottom of your screen. We apologize in advance that we will be likely unable to get to all of the questions, and we also will not be able to answer specific clinical questions for individuals. We encourage you to speak with your doctor as well as to go to pcf.org for more information. We did receive several excellent general questions about prostate cancer treatment in advance of the webinar, and many of them are addressed in our patient guide. So I encourage you to get the guide if we can't answer your questions today. Here's our agenda for today. We'll be speaking about the VA partnership in PCF, genetic testing, ADT, sexual side effects, and finally, clinical trials in prostate cancer. We've chosen these topics as we get a great deal of interest and questions from our readers and in our Facebook groups. These are all very deep topics, and we could certainly spend an entire session around each one. But today we hope to cover the essentials as well as get to some of your questions. Our first speaker is Ms. Rebecca Levine of PCF. She is the Chief of Staff and Vice President of Government Relations and Advocacy. One of her primary areas of focus is to collaborate with government officials and prostate cancer experts to lead the coordination of a precision oncology initiative to expand prostate cancer clinical research among veterans. The aim is to speed the development of new treatment options and cures for prostate cancer patients. Welcome, Rebecca.
Thank you so much, Becky. And I'm just going to quickly just share some slides. Hold on just a moment here. Great. Thanks, everyone. And thank you, everyone. And I'm so glad to be here during National Military Appreciation Month as it comes to a close, and we salute the brave Americans who have served on our armed forces, and we honor their sacrifice, patriotism, and courage. By way of introduction, the Prostate Cancer Foundation, as Becky had alluded to, is the largest source of philanthropic support for prostate cancer research. Since 1993, we have raised over $860 million in philanthropic funding for research and championed the need for investment in breakthroughs across a broad range of stakeholders, including academic, industry, and government partners. Prostate cancer is the #1 cancer diagnosed among veterans, and prostate cancer rates in the military are twice those of the civilian population, which made our partnership with the VA one that was both practical and also deeply a part of our mission. In 2016, the Prostate Cancer Foundation committed to fund $50 million in precision oncology research initiatives to speed the development of new treatment options and breakthroughs for prostate cancer patients. We're funding centers of excellence across the United States towards a system of excellence serving all veterans diagnosed with prostate cancer across the VA. And this is a reflection not only of our mission to end death and suffering for prostate cancer, but also the solemn duty that our board has undertaken since inception. And in this photo, you'll see 3 of our board members, 2 of whom served in the military and who also served on countless clinical trials for prostate cancer and left a legacy of executive leadership that brought us to our PCF-VA partnership. This is an overview of our centers of excellence collaborating, and this map is actually out of date because our partnership with the VA is scaling well beyond these 13 centers that PCF is funding. Through this partnership, and 3 of the clinicians who are on the phone today are a central part of the work we're doing. We are speeding medical breakthroughs not only for veterans, but also for all Americans who can benefit from this public-private collaboration. And thank you so much. My email address is here. If anyone has any questions, feel free to email me. And with that, I'll stop my sharing and give it back to my colleague, Becky Campbell.
Thank you so much, Rebecca, for that overview. Next, I'd like to introduce Dr. Julie Graff. Dr. Graff is Associate Professor of Medicine at Oregon Health and Science University Knight Cancer Institute, and she's also Section Chief of Hematology Oncology at the VA Portland Healthcare System. She has done extensive research in immunotherapy for prostate cancer and received a 2018 Movember Foundation PCF Valor Challenge Award to investigate how changing the gut bacteria of patients with advanced prostate cancer may affect their response to immunotherapy. Welcome, Dr. Graff.
Thank you. I'm honored to be here. So I also at the VA work very closely with Rebecca, and one of my major roles is directing the Clinical Trials Consortium. So in my next talk, I'll get more into that. But first, the miracle of sequencing the human genome. This is something that's been an incredible achievement for mankind. I remember working in a lab in the year 2000 at Children's National Medical Center with a man who cloned the gene for Duchenne's muscular dystrophy and learning the initial results. So in 2000, the initial draft of the human genome was published. And just hearing, it just was one of the most exciting experiences for me. And as we've gone through time, we've been able to actually apply individuals' genetic findings to treatment and for prediction of outcome. And part of that is because while it was originally very expensive to sequence a genome, $100 million here back when we had our first draft, the cost of sequencing the genome has gone down, and we've found other ways to test specific genes that are implicated in prostate cancer. One thing that is difficult to understand is that when we talk about genetics, we talk about the germline, which means every cell in your body, and it's also those cells that can be passed on to your children. And we also talk about somatic mutations. Those are the mutations that are present in the tumors themselves and not necessarily in the germline, although occasionally a mutation may be present in both. So there are many indications to do germline testing. And as patients have metastatic prostate cancer, there become indications to do the somatic testing. The reason this is looking at a very important paper, I don't expect you to be able to read this, but we went from the draft of the human genome in 2000 to actually looking at tumors in prostate cancer patients where the patients had received therapy in the past, and now we were looking to see what are the mutations in the prostate cancer and trying to learn if we could target those mutations or not. And when I say mutation, in case it's not clear, I mean, it's different. There's a mistake, and mistakes happen all the time in our cells, and the cells have machinery to try to fix those mistakes, but they don't always get fixed. And sometimes they lead to cancer, and sometimes they lead to resistant to cancer treatment. So in this paper, they looked at 150 patients and really defined what are the mutations present in very advanced prostate cancer, in this case, metastatic castration-resistant prostate cancer. So how do we test these tumor mutations? So somatic, as I mentioned, those are the cancer mutations that are present in the tumors, but not necessarily in all your cells. One of the most common ways to look for mutations, and the way that they did it in that paper I just showed, is they took a biopsy of the tumor, and then they took the tissue that they got out of the biopsy, and they looked at the DNA of the tumor to find mutations. However, in prostate cancer, not everyone has a tumor that can be easily biopsied. In fact, many of our patients have tumors in the bones, and as soon as prostate cancer goes to the bones, it causes bone growth and formation, and it can be very difficult to biopsy those areas. So there is an alternative called the liquid biopsy. We've learned over time that actually the tumor DNA is shed into our bloodstream. So if you took a tube of blood from someone who has cancer, you could look for DNA that's from the tumor that just happens to be floating around in the blood, and look for mutations that way too. And in many cases, that's more successful than biopsying a bone tumor. However, it does depend on like how much cancer the person has and how much tumor DNA is floating around. So when we do these somatic tissue or somatic tumor analyses, we're often looking for very specific mistakes and very specific genes. And those genes are what code, proteins and do the actions in your cell. So the question became, well, we learned all this information from that one paper I showed. Well, can we do anything about it? Because in 2015, we couldn't really do anything about it. We might be able to identify a mutation and just say, hey, this person has this mutation, but not yet really be able to do something specific to that mutation. And we have learned that actually, yes, you can act on those mutations. And I will give you some examples. A quick aside, these are our guidelines. The National Cancer Clinical Cancer Network puts out guidelines for oncologists and other providers about how to treat patients with cancer. And the germline, which is the cell that's present in all your body, it's indicated that we test for germline mutations, even if you have like advanced disease that's not really spread into tumors that we can see on scans. And when someone has metastatic prostate cancer or tumors that you can see on the scans, it's always indicated to look for the cancer in those tumors. Furthermore, you can look at the cancer itself, but you could also clearly look at the family history. One of the most common mutations, or at least that we can act on, is the BRCA2 mutation, which is also implicated in the formation of ovarian and breast cancer, as well as prostate cancer. So one of the successes in cancer therapy the past 10 plus years is actually immunotherapy, where we harness the immune system to kill the cancer. So it's not a chemotherapy, it's not a hormonal therapy. In this case, it's actually a little antibody that interferes with the negative signaling between the immune system and the cancer cell. So one of the reasons the immune system doesn't always clear out cancer, even though it's not supposed to be there, is that the cancer may have the ability to turn off the immune cells before they can kill the cancer. So these types of therapies, you may hear PD-1, PD-L1, pembrolizumab as an example, are approved now. I think one of the questions was about how many cancer types it's approved in. It's approved in more than 12 cancer types. And one thing that we've really learned about this drug is that when there's a tumor with a lot of mutations, that tumor may be making new proteins that the body hasn't seen and may be particularly susceptible to pembrolizumab. In prostate cancer, as you can see here, that kind of mutation it has a lot of names. We call it microsatellite instability, mismatch repair deficiency, and tumor mutational burden is only present in 3% of patients with prostate cancer. But I happen to be treating a veteran who had that mutation with pembrolizumab, and it can work quite well in that case. The other arm that we can target are those BRCA2 mutations that I mentioned. So I also mentioned that DNA is constantly making mistakes. Like every time your cells divide, your DNA has to replicate so you can get some in each of the cells. But it also is damaged, by radiation and other things. So when in the body or in the cell, there's a double strand DNA break, it's a double helix, it's two strands wrapped around each other. The body only has two ways to repair it. One of those ways is through PARP, and one of the ways is through homologous recombination, which is a mouthful. If the cell is missing that homologous recombination, and classic examples of that are mutations in BRCA2 and mutations in BRCA1, and then you block the PARP here down at the bottom, then the cell will die. It doesn't have any way to repair its double-strand DNA break. But these PARP inhibitors are not effective in patients whose tumors do not have that kind of mutation. That sort of mutation is present in about 20% of advanced prostate cancers, but when you find it, it's very important. So Triton-2 is one example of a clinical trial with a PARP inhibitor called rucaparib, where they were able to show in patients with certain mutations in the tumor that there was a good number of responses. This is actually a phase 2 trial, and the phase 3 trial is still enrolling. Here's the phase 3 trial. I will talk a little more about it when we talk about clinical trials. In conclusion, this subject is huge, but I would like to drive home the point that it's very important, and that if you have advanced prostate cancer, by that I'm defining it as metastatic in particular, it's really important to get your tumor sequenced. The treatments that are geared at certain mutations, so far there's just two, homologous recombination deficiency and that microsatellite instability, can help people live longer and better quality of life. So that is one of our missions in treating our veterans. Thank you.
Thank you, Dr. Graf, for just an introduction of a very complicated and very important topic. But that's a great take-home message for veterans and all patients to, if you meet certain criteria, make sure to talk to your doctor about sequencing and what that might afford you in terms of treatment. Next, we're going to welcome Dr. Ravi Parikh. He's going to talk about side effects of ADT. Dr. Parikh is Assistant Professor of Medical Ethics and Health Policy and Medicine at the University of Pennsylvania. He's also a staff physician at the Corporal Michael J. Crescens VA Medical Center. He received a 2020 PCF Valor Young Investigator Award to develop new clinical biomarker tests that can identify which patients undergoing hormonal therapy are at risk for developing bone fractures and should be prescribed early bone maintenance therapies. Thank you so much, Dr. Parikh.
Thanks, Becky, and thanks everyone for inviting me on this talk. It's really an honor to talk about a really common therapy that we give to treat prostate cancer, which is androgen deprivation therapy, and what you should expect. So I just wanted to start by acknowledging my disclosures and talking through a little bit about what I was going to discuss today, which is 4 parts. First, what is androgen deprivation therapy and why do we use it in prostate cancer? Second, what side effects should veterans and non-veterans taking androgen deprivation therapy expect? Third, what are the long-term side effects to watch out for, potentially silent side effects? And then fourth, and most importantly, what can we do, both as patients and physicians, to help reduce risk from androgen deprivation therapy? So I just wanted to take you through a representative case of a patient who I saw in clinic actually a couple of weeks ago, who we had just started on androgen deprivation therapy for advanced prostate cancer. So this patient had started taking ADT probably around 2 to 3 weeks before I saw him, and he was just coming in. He was complaining a lot of hot flashes, which were probably his biggest issue with taking the medication, saying that, every day, probably about 5 to 6 times a day, he was experiencing quite a bit of hot flushes and flushing that required him to shed many layers of clothing and stand in front of a fan. And keep in mind, this is around the time that Philadelphia is turning a little warmer, and so this is a little bit more of an issue for him now. He was also saying that fatigue, although not his biggest issue, was certainly an issue. He enjoyed playing with his grandchildren on a daily basis in the afternoons, and was saying that he just didn't have the energy to keep up with them. He, like many other men who come into my practice, was also noting that he was having to take a nap during the day when he normally didn't have to take a nap. Third, he was noticing that he was experiencing a lot of difficulty achieving an erection, and more so just having a lot of decreased libido or desire to have sex with his wife, whereas previously he had enjoyed quite an active sex life. And then fourth, if he was like many of my patients, probably around 6 months to or several months after he started ADT, he would notice that he had started to develop a little bit more fat around his belly, what we kind of call visceral adiposity, but just an accumulation of fat in places that he hadn't accumulated fat before. So unfortunately, these are common side effects of androgen deprivation therapy, and things that we are frequently counseling patients to expect before they start. And it all has to do with the biology of how androgen deprivation therapy works. So ADT, as we call it, is oftentimes called hormone therapy, and it's how I'll oftentimes refer to it in clinic, and how many of you may know it, for those of you who have received or heard about it before. And the essence of what ADT does is reduce your body's ability to produce testosterone, or it blocks the effect of testosterone and other similar compounds like androgens from having an effect on different parts of the body. And so that is what causes a lot of the side effects that ADT initiates. ADT can either be given by mouth or by injection. And the most common way that we give it in our clinic for men who are starting is by an injection every 3 to 6 months. Many of you will have taken ADT injections, but have a 30-day or so pre-period where you're taking an oral drug daily to try to reduce some of the potential immediate term side effects of the injections, or we to just give them alone. But those are the most common ways that we give them. ADT is very common. It's one of the most common medications that we give. And I know this is a talk about ADT side effects, but I feel like it would not do it justice without talking about a lot of the benefits, or why we give ADT in the first place. ADT is, like I said, one of the most tried and true therapies in prostate cancer, and reduces one's risk of death. And this is not progression, this is death, by up to 23% if you were to receive a prostatectomy for localized prostate cancer. If you were to receive radiation, then for certain high-risk prostate cancer, ADT could be associated with up over 30% reduction in risk of death. And then for stage 4 prostate cancer, ADT is the backbone of what we do for prostate cancer that is spread beyond the prostate, and has been used since the 1940s, or even before that, for helping to treat advanced prostate cancer. And we've since layered on top of the ADT backbone other types of therapy, but ADT has sort of been the commonality. So ADT is very useful in treating the disease that all of us are treating as clinicians. So, and despite its side effects, you can see a lot of the potential benefits here. And by extension, it oftentimes prevents some of the devastating consequences of prostate cancer, such as fractures, that while they may not kill you, will certainly cause a lot of quality of life issues. So let's talk a little bit about ADT side effects. Many of you, for those you take it, this will be common knowledge for you. And I like to break it down when I talk to patients in terms of side effects that you see and side effects that you don't see. Side effects that you see are often can be classified into a few different categories. Sometimes it's how you look, like hair loss and growth or weight gain and loss. And a representative question that I oftentimes get is, why is my stomach getting so much bigger? Oftentimes it can cause issues with sexual dysfunction, and Dr. Loeb is going to talk about this in the next talk. But oftentimes men are complaining why I can't perform in bed like I used to. Other types of side effects are behavioral health related, issues with mood, libido, and memory and concentration. Another common complaint is I get irritated at my wife and kids much more than I used to. It's a common complaint that I hear. And then there's issues with muscle and bone. Oftentimes men are saying, my arms feel flabbier than usual, pointing to the loss of muscle mass that comes about. Much of this is related to a metabolic syndrome that men with ADT undergo. Up to, there's very high statistics around loss of muscle mass, rise in triglycerides and blood sugar, and then other types of issues with visceral adiposity that are all part of this metabolic syndrome. So those are things that you can see, but what about the things that you can't see? Well, I'd like to talk about three main issues, one related to mental health, and oftentimes this goes unnoticed by clinicians or by patients. But up to 41% of men receiving androgen deprivation therapy will experience depression or anxiety related to their use of ADT. And this also oftentimes translates to an increase in risk of suicide as well in certain studies, although the evidence there is a little bit more mixed. Heart disease is another issue that oftentimes is a consequence of the metabolic syndrome that ADT engenders. Heart disease can take the form, heart disease related complications have been associated with ADT in the form of things like heart attacks and coronary artery disease, oftentimes which has somewhere around a 10-20% increased risk associated with ADT. And then there's issues of bone health, and that oftentimes occurs because ADT relates to decreased bone density in a lot of the bones that particularly long bones in your vertebra. There's been some studies that suggest in the ADT era, somewhere around about 10 to 20% of men will experience a clinically significant fracture at 10 years. And so this is really important to be on the lookout for, and that we can oftentimes prevent through routine screening. So what can you do to prevent a lot of the risks from ADT? So the first thing I would say is that no side effect is too small to be mentioning to your clinician. And so I would say that I oftentimes encourage my patients to keep a list of things that they're feeling, because oftentimes these things aren't unaddressable and we can address them. But here are a few common tips that I often recommend for dealing with the common side effects. First, dress in layers, especially in the summer, for the reasons I mentioned before. I will usually prescribe a daily calcium vitamin D pill because one, it's usually not associated with a lot of side effects, but two, it can help prevent a lot of the side effects related to bone health that I mentioned. For those with pre-existing issues with cholesterol, blood pressure, or diabetes, remember to take your medication. Taking medications and being adherent to them is more important than ever for men on ADT. Aerobic and resistance exercise is also important. And then cutting down on smoking, keeping up with colonoscopies, and joining support groups are oftentimes recommendations from guideline-based societies like the American Cancer Society. There are several apps, including ones that the ACS puts out, that publish guidelines for men on ADT that are important to look at, and oftentimes the ones that I follow in a checklist type of format when I see my patients with ADT. And then what should you be asking your doctor? Well, these are some questions that I would encourage you to sort of ask your doctor when you're on ADT, because they can oftentimes change your treatment plan. So the first is sexual health is something that, as Dr. Loeb will say, we'll talk about a little later, is oftentimes unnoticed and unmentioned by a lot of patients, but is really important to note. And so I would ask whether there are counseling services or medications or even devices that are available, I usually have to prod my patients to try to mention these side effects. And so I think it's important to bring up. Another important aspect is avoidance of ADT when you don't need to be on it. Oftentimes for men who don't have advanced disease, and even some men who do, I'm pursuing an intermittent ADT approach where I'm taking patients on and off of ADT depending on how their disease is progressing. And that can oftentimes reduce a lot of the continual buildup of side effects that come with it. Are medications okay for my hot flashes? We tend to underutilize medications for hot flashes because we assume that they're just mild, but some hot flashes are very significant in patients' lives, and there are medications that have been proven to help deal with them. Physical therapy and nutritionist support, these are often services that are available at your health center, including at the VA, and can really help with a lot of the fatigue-related consequences of ADT. And then I'd really encourage you to ask about who's monitoring my sugar, cholesterol, and blood pressure, which should be routinely checked for men on ADT. Oftentimes, this sort of gets missed because men are being seen in both the primary care and the oncology or urology or radiation oncology setting. And so no one's really assuming that really important aspect of care, but we really should be. And then should I be on a medication to protect my bones other than calcium, vitamin D, which some men should. So I wanted to just close with a couple of really common questions that I get. So whenever I explain to men that ADT reduces your testosterone, many will say, well, why can't you just give me testosterone back whenever my prostate cancer is under control? And so one of the big reasons is because given time, testosterone will recover to normal or recover to near normal after 1 to 2 years, or even sooner, closer to a 6-month period for some men as well. And so given time, many of these side effects will return, but it can be slow. But the bigger thing that we sort of worry about is that testosterone supplementation can actually lead your prostate cancer to come back, since prostate cancer feeds off of testosterone. And so evidence is sort of mixed depending on one's risk of prostate cancer, whether this actually does occur, whether once you've taken ADT, supplementation can actually increase your risk of prostate cancer coming back. But at least until I see better evidence, I get really nervous and likely won't be recommending testosterone supplements to address ADT side effects, unless in very specific sort of lower risk scenarios. And then there's been a lot of increasing data around dementia, things like Alzheimer's disease. And in fact, we've put out some work in using large databases that suggest that there is a small but significant risk of increased Alzheimer's risk associated with ADT. The thing to remember here is that most men, the vast majority of men taking ADT, won't experience a diagnosis of dementia and won't experience serious or noticeable side effects in your thinking or cognition. But there is a theoretical risk. And so for men who have pre-existing dementia or who are already showing signs, oftentimes we'll do some preemptive counseling about that for them and their caregivers. At the VA, there's a number of resources available for those of you who receive care at the VA to manage side effects of androgen deprivation therapy. These include exercise programs, behavioral health, acupuncture services, and mindfulness training. And so I'd encourage you to ask your broader VA staff about whether these resources exist. And then what's coming down the pike are novel technologies to help detect side effects from ADT, like bone health consequences. And then new types of ADT, including an oral pill called relugolix that has been recently shown within the past year to not only reduce testosterone at a more significant level, but also when it's removed, say, for example, if you're only taking this ADT for a shortened time period, it can also have associated with a more rapid recovery of your natural testosterone. And most importantly, a dramatic lowering in your risk of cardiovascular complications. And so these are types of, these are sort of really big advances for managing a lot of the side effects that are associated with ADT. So thank you all, and I'm excited to ask any other questions, to answer any other questions later on in the talk.
Thank you so much, Dr. Parikh. Really appreciate that very clear and visual presentation of these medications that can really impact the lives of many of our men with prostate cancer. We are going to briefly turn it over to Dr. Groff, who's going to give an overview of clinical trials, obviously extremely important in bringing any new therapies to the public, to patients, from COVID-19 vaccines all the way to very sophisticated immunotherapy for prostate cancer. So she's going to give an overview of clinical trials and potentially some resources if that's something that you want to discuss with your doctor. Thank you, Dr. Groff.
Hi again. I know I've been reading the chat, and I know that these concepts, the genetic one was very big, and it's tough because I think people in the audience probably have different levels of experience with things. So I just there's a lot more to be explored, and there are other conversations going on, and we can help you find more appropriate learning opportunities. Also, I didn't say my disclosures with my slide, but I do receive clinical trial funding from multiple pharmaceutical companies, but I don't personally receive any money from them. So last night, I looked online at a very useful website called clinicaltrials.gov to see how many trials were there in prostate cancer. And you can see here I found 5,122. So this is a website where clinical trials have to be registered in order to be published and in order for the drugs to become FDA approved, or there's a lot of regulatory things behind it. And I do access this website with my patients from time to time to see if there are any clinical trials available to them. So I'm just pointing out that there's a lot of work being done in prostate cancer, and that's so important. I'd also like to point out that, and a lot of my talk is about, or even the last talk was about metastatic castration-resistant prostate cancer, which is cancer that you can see on a scan and is no longer responding to just pushing the testosterone down. And, you know, between 2004 and 2020, we've had quite a few new approvals for that metastatic castration-resistant prostate cancer. However, there are no cures, just incremental increases in overall survival. So until we can cure it and make it, you know, tolerable, then we're going to keep doing research. Fortunately, you know, research has paid off. I understand, though, not in time for a lot of our patients. So clinical research is my field. I design clinical trials for patients with prostate cancer. And I just wanted to give you a quick overview of what I mean by clinical research. So first of all, there's stuff that happens before drugs ever get into a patient. And that's really important to, you know, do very basic research to see if the drug, for example, is binding to whatever it's supposed to bind to, or doing whatever action it's supposed to do. And then it moves into animals to look at safety data. And when all that work is done, investigators or researchers, you know, they write a protocol to see what dose of the drug might be effective without being too toxic or having too many side effects. And those are phase 1 trials, when you're trying to find the right dose of a drug. The goal of all clinical trials, the most important thing is patient safety. So in the phase 1 trial, we're using a drug that has not been used in humans before, most likely. As the trial enrolls, we learn more and more. But it's important to just treat a very small number of patients until you get the dose that you think is safe and effective. And then you move into phase 2 trials. And phase 2 trials are designed to see, well, what is the effectiveness of this drug, or in studies we call it efficacy. So often phase 2 trials don't have a placebo, and placebos are like a treatment that doesn't actually have the drug in it. Sometimes they're referred to as a sugar pill, but most phase 2 trials, everyone gets the treatment. And then finally, if you establish that there is a lot of activity of one of these new drugs, then you move on to phase 3 trials. And those are the trials that get drugs approved for everyday use or for patients. And those trials often use a placebo, or they might say physician's choice. And I'm going to get into that in a minute, because I'm going to give you an overview of the VISION trial which I promise I'll get into. And then once the drug gets approved and patients are using it, then there's a phase 4 portion, which is you can collect data with the patient's permission on how they do. Like you can get more patients on and learn even more about the drug and even come up with ideas for other clinical trials. So I mentioned in the last talk on genetics, the Triton-3 trial, which is a phase 3 trial, meaning we're comparing two groups. The goal is FDA approval of this drug. And the drug is rucaparib. So rucaparib is one of those PARP inhibitors where if you get the double-strand DNA breaks and the patient has a mutation where they can't repair their double-strand DNA break and you block the PARP pathway, then the cell dies. So for all clinical trials, there's what we call eligibility. So like we want to make sure that the people who participate in the trial first need to be on the trial. So like, for example, you wouldn't put someone on a trial when there's an effective agent already available. That would be, unethical to deprive someone of an active treatment that works to put them on a clinical trial. You have to often see that the cancer is growing. There has to be some evidence. And I see a lot of patients in my clinic where they're doing great and they come to me to talk about clinical trials, which is fantastic because we can talk about the future for them. But if they're on a drug and they're doing great, we usually don't put them on clinical trials. In this trial, patients had to have had, so they got somatic testing, either by giving blood or a biopsy of a tumor. And they all had BRCA1 or 2 mutations. The ECOG is something you'll see a lot. It has to do with how active a patient is. So you have to be out of bed more than half the time to really participate in a trial usually. And in this case, they couldn't have received chemotherapy yet. And they got randomized 2 to 1. So for every 3 patients, 2 went on to receive the study drug rucaparib, and 1 went on to get either docetaxel or abiraterone. And it was up to the treating physician. And the patients stayed on their treatment until the cancer grew. And in this case, if they were assigned to the physician's choice arm, they were able to be crossed over to the rucaparib arm. The primary endpoint. So before you ever start a trial, you have to think about what you're going to measure. And a lot of our trials, typically phase 2, use radiographic progression-free survival, meaning they do bone scans, they do CAT scans, and when they see that the cancer is growing, they say, you should probably be on something else. And then there are secondary endpoints. Every trial has them. It's always safety. You're always collecting information about side effects. It's up to the investigators and the patient. We discuss like how likely it is whatever side effect you have is related to the study drug versus something else. The results of this trial are not yet available. They are still enrolling patients, and we have it open at multiple VAs, which is pretty exciting. But probably in a couple of years, we'll have information on this one. Now, we talked about rucaparib in the last slide, and now we're moving into olaparib. Rucaparib and olaparib belong to the same group of drugs called PARP inhibitors. That's another thing that can get kind of strange when we talk about drugs. It's like there's so many drugs that belong to the same group. For example, some of you have heard of enzalutamide, apalutamide, and darolutamide. They're all in the same group of drugs. They all work the same way. Likewise, this olaparib works just like rucaparib. The difference in this case is that the trial is done and we have information. So the inclusion criteria were similar and the endpoints have been reached. And this trial showed that treatment with olaparib is superior. Patients live longer, and they had a longer time until more tumors showed up on their scans compared to the physician's choice. And in this trial as well, patients were allowed to cross over. So I'm like jumping from one major thing to the other. So to summarize, there's many phases of clinical trials. If you look, you can look online and see all the clinical trials that are available for prostate cancer. And you probably need your physician's help to find out where you fit into all that, or where your cancer fits into all that, because it can be sometimes pretty confusing. The treatments we have today were approved on clinical trials, phase 3 clinical trials. There are very recent clinical trials, such as this study I'm talking about with olaparib. It led to the approval of PARP inhibitors in prostate cancer just last year. And there are other phase 3 trials underway. And I'm going to talk to you in just a moment about another study, but it looks like I'm going to segue for just a moment here. And I saw in the chat box too, there's a lot of questions about, imaging. And today, it's so great that we have this talk today, because today, the Food and Drug Administration approved this PSMA PET scan. What in the world is that? Well, you might have heard of PET scans. They've been around for a long time, especially if people with melanoma, people with lymphomas. But now we have one for prostate cancer. So prostate cancer didn't really show up on the old ones. But now with this PSMA PET scan, we are giving patients a tracer in the vein that will go to prostate cancer. PSMA stands for prostate specific membrane antigen. So it's attracted to cells that are expressing that, and then it'll light up. It's much more sensitive than a bone scan, which you can see here on the left. Bone scan's been used for probably 2 decades. It can pick up something the size of a marble, let's say, versus this PSMA PET can pick up something the size of a grain of rice. It also, as you can see further to the right, it lights up. It gives you more of a sense of size of things versus the bone scan. It's like something's lighting up versus not. It's approved as of today for those patients who present with the concerning findings. For example, let's say a patient has a very high PSA of 100, and we think all the cancer is still in the prostate. And then if we do surgery to remove the prostate, we might be able to cure it. But that PSA of 100 makes us wonder, has it already spread? And this would be a good time to get the PSMA PET to see if it has spread. The second time you can use it is when patients have a PSA that's climbing up after treatment of the prostate gland. So they get either surgery or radiation. Everything's fine. Over the years, the PSA begins to creep up. No other organ makes PSA. So that indicates that there's still some prostate cells and prostate cancer cells, more specifically in the body. Most of the time, we can't see anything on our traditional scans until it's like 10 to 20. Your PSA is like 10 to 20. But these are very sensitive, and you can see things even when it's under 1. And it can help you make decisions as to what to do next. And I took this straight from the PCF website today. Finally, my last slide, because I am so excited to go to the American Society of Clinical Oncology meeting virtually in 1 week and see all the new trials, the new data that's available. This one is something that's generating a lot of excitement. Again, we're looking at PSMA specific to prostate cancer. It's not 100% specific, but it's pretty specific to prostate cancer. They've now, not only can you image, like put something on with a PSMA antibody that will light up, but you can treat. So in this VISION trial, they took PSMA antibody and they attached to it a radiopharmaceutical, so something that emits radiation. And they gave it to patients. Patients were allowed to be on drugs like abiraterone, enzalutamide, and they were randomized to receive just like the standard of care or standard of care plus lutetium-177. So that's a radioactive particle that's attached to PSMA. The results are going to be discussed in 1 week. There's a press release that they're promising. And so we will all learn together how this phase 3 trial turned out. Very briefly, I'm, like I mentioned earlier, running clinical trials at the VA, and I'm very, very interested in putting veterans on trials. I don't want to take up Dr. Loeb's time, so I'm going to end there.
Thank you so much, Dr. Groff, for that overview of clinical trials and also for the preview and kind of summarizing the exciting development today with the approval of PSMA PET PYL imaging agent, as well as the preview of the VISION trial results to come next week. And without further ado, I'd like to introduce Dr. Stacy Loeb. She is a professor in the departments of urology and in population health at NYU Langone School of Medicine and at the Manhattan VA. She has received PCF Young Investigator and Challenge Awards and is currently studying digital communications in prostate cancer, among other topics. Dr. Loeb is an expert reviewer of PCF's Prostate Cancer Patient Guide, and she also hosts the Men's Health Show on Sirius XM. Thank you so much, Dr. Loeb.
Great. Thank you so much for having me. And hello there, everybody. Really great to be with all of you. So just to give a little bit of a background, as you know, the prostate is an organ in men. And unfortunately, it is in a challenging location, kind of high price real estate, because it is right near the bladder, the urethra, the rectum. It's near the nerves that are involved in erectile function and the muscles of the pelvic floor. So, you know, unfortunately, both prostate biopsies and all forms of prostate cancer treatment do have the potential to lead to sexual side effects. So just to frame the discussion, we could think of a typical case scenario of a veteran who is diagnosed with an intermediate risk prostate cancer and comes to our office to discuss possible interest in surgery, which is called a radical prostatectomy, but is concerned about sexual function. And indeed, there are many different possible side effects, both from surgery and other forms of prostate cancer treatment. And this can include pain with orgasm and ejaculation or lack of ejaculate, leakage of urine associated with an orgasm. There can be changes in the penis, including shortening or curvature, loss of libido, which is particularly the case with androgen deprivation therapy, which we heard about a bit earlier. And the biggest complaint is erectile dysfunction. So why do these things occur? There's a lot of different mechanisms involved in this, and some of it is the endothelial lining of the blood vessels, damage to those muscles in the pelvis, and injury to the nerves related to surgery. So in terms of erectile function recovery, studies are all across the boards. This slide shows a meta-analysis. You can see the lines for all of these individual studies, and some of them have higher rates and some have lower rates. But, you know, the conclusion here was about 56 to 58% erection function recovery. And, you know, it does vary on an individual level, and there's a whole lot of factors that affect the return of erections. So, and this includes the patient's age, their testosterone levels, other health issues that they have, particularly of the cardiovascular system. In order to have blood flow to the penis, we have to have good circulation in the body. So people who have a lot of buildup in their arteries, they're going to have more difficulty with erections. Preoperative function, so, and the same would be true for having radiation therapy or otherwise. For surgery, very important is the surgeon's experience and surgical volume, as well as the technique of the procedure and the extent to which the nerves that are controlling erections are able to be spared during the surgery, and, you know, what happens post-operatively. Another key consideration is timing. So with something like surgery, the greatest hit to the sexual function is right up front. And you can see this graph, which goes out to 2 years, where there is some gradual recovery over the course of a 2-year period. I saw we had a question that came in with an individual who is 1 year out, and there can be additional recovery after that time, as you see on this graph. The good news is there are a whole lot of different treatment options, and this ranges from things like mechanical devices. There's multiple medical treatments. This includes oral medications. There's suppositories that go into the tip of the penis, injections into the penis, which can be quite effective and can be taught to patients and their families. Surgical options, and last but not least, and maybe even most important, is the importance of psychosocial support. I would be remiss not to take this opportunity to just highlight the importance of lifestyle optimization for sexual health. We did get a bunch of questions that came in regarding diet, exercise, things like that. So for sexual health, it's very clear. So smoking is a big problem. So definitely avoiding smoking is very important. Sleep is very important. There are links between sleep apnea and other sleep disturbances with poor erectile health. So getting a good night of sleep, whether it's taking up some kind of mindfulness or meditation, anything that will help you to relax and be sure to get a healthy night of sleep. Exercise, essential, as I mentioned, hardening of the arteries and flow of blood is, throughout the entire body. So physical fitness and maintaining a healthy weight is very important. And diet. And this goes along with prostate cancer recommendations, erection recommendations, and cardiovascular recommendations. You really want a plant-forward diet, lots of fruits and vegetables, and definitely avoiding of red and processed meat, which are associated with an increased risk of erectile dysfunction and are also just not ideal for prostate cancer anyway. What is new in sexual health? So I want to at least talk a little bit about what's happening right now. And obviously the elephant in the room is the COVID-19 pandemic. And it certainly has had a huge impact for prostate cancer as a whole. We've seen less screening, less diagnosis, delays in treatment, also interruptions in research. And so I think this will have, sadly, a long-term impact for prostate cancer with researchers working on COVID-19 and less funding to prostate cancer. But on the survivorship side, what we're seeing is things like cancellation of support groups. Luckily, there are some virtual groups by Us Too and other organizations. A question came in about that. So thankfully, some groups have pivoted activities for survivors to an online format, but not totally. And, a major problem as it pertains to this specific topic is the cancellation of a lot of visits and surgeries for sexual health and other quality of life issues. So actually, this is already a big problem. We already have under-treatment of sexual health issues in prostate cancer survivors, and very important that these issues are addressed. But here's just some data for COVID-19 specifically. This was a survey that we sent out to urologists around the world, actually, on the reduction in the volume of different types of visits that they're seeing. And you can see here, prostate cancer had the greatest reduction of all the different cancers, but even more so, visits for sexual health had a huge reduction. So many people were just not getting treated for any of these issues during the pandemic. And correspondingly, this was kind of an interesting study that came out looking at Google search trends and showing less public interest in some different treatments for sexual health during the pandemic. So not surprising, people have been very busy with other things, but it is important that we get back to this and make sure that unmet needs are addressed. So along those lines, we are happy to have recently initiated a grant from the Department of Defense evaluating the impact of prostate cancer therapy on sexual quality of life for couples. And since this really is a couples disease, it's important that we understand and address the needs of partners who are affected as well. So we did start during the pandemic some qualitative analysis where we looked at posts to the Inspire Us To online community related to sexual health and intimacy to get a better understanding of some of the unmet needs and themes that were being discussed by patients with prostate cancer and their partners. And, not surprisingly, erectile dysfunction was the most common specific sexual issue that was discussed. But, there are a lot of recurrent messages that came through. So a lot of coping and adaptation to kind of the new normal after prostate cancer treatment, which in some cases includes expansion of the sexual repertoire and trying different types of sexual activities. There's also discussion about quality versus quantity of life and some of the trade-offs that may be involved in certain types of therapy. Certainly, some individuals express regret over treatment that they had received or frustrations with clinicians and the healthcare system. There's no question there is a lot of unmet needs for information, better access to erectile aids, very limited access to psychosocial support, and partners need that too. There is a lot of grief among partners and feelings of invisibility. So extremely important was the theme of communication between partners throughout this process. So this research is continuing, and the next step is we will be recruiting partners of patients with prostate cancer for interviews. So if any of you who are listening are interested or know anyone who would like to hear more about our work or get involved, please reach out to us. You can send an email to either of the study coordinators who are listed on this slide. And so coming soon, what are we going to do to address some of these issues? Well, first of all, I'm excited to announce that we are working with the PCF and developing some new resources that address some of these topics, which will ultimately be released on PCF's website, pcf.org. So stay tuned, there is more to come. And additionally, a separate effort led by one of the collaborators on our grant, Dr. Daniela Whitman, is the True North International Guideline for Sexual Care during prostate cancer survivorship. And so I was honored to participate in this along with a large multidisciplinary group. It will hopefully be finalized within the next year and provide a framework for the optimal management of sexual health in men undergoing different types of prostate cancer treatment and their families. But in the meantime, I want to leave you off with some resources because this is way too brief to address the whole realm of sexual health issues in prostate cancer. So there's some wonderful websites out there. The PCF guide you heard about earlier is a fantastic resource. And there's some other really great websites that address sexual health and prostate cancer specifically. There's also an online program. So if you don't have something locally and are interested, you can go to the University of Michigan's Rogel Cancer Center website, where they have a 6-session tailored program related to sexual health recovery. So I would encourage you to check this program out if you're interested. There are also online health communities, and this includes Inspire, who we have collaborated with on our project, as well as the PCF's Facebook groups. So if you don't have a group locally or would find it helpful to get information and support from others who are experiencing similar issues, I would encourage you to get involved in one of these online groups. There's also a number of books. So our sexual medicine expert recommended a few specific titles that more specifically focus on sexual recovery after prostate cancer treatments of different types. And of course, finding a practitioner. So some of the disdain that we saw related to clinicians is because in urology, different specialties manage cancer and sexual health. So often a urologic oncologist is the type of doctor that does surgery for prostate cancer, whereas sexual medicine is a different fellowship and a different subspecialty. But if you have not seen a sexual medicine expert and would find that useful, the Sexual Medicine Society of North America has a Find a Provider tool to find urologists with this particular expertise. And additionally, psychosocial support is really important. So if you'd like to find sexuality educators, counselors, and therapists, you can look at the AASECT or the SSTARnet websites to look for these providers in your area. I'd like to thank the Prostate Cancer Foundation, the Berry family, and the Department of Defense for supporting our research, as well as my collaborators. And of course, to finish off this webinar, I'd be remiss not to acknowledge Military Appreciation Month. My grandfather was a veteran with prostate cancer and is the reason that I chose this field. And I just want to thank all of you for your service.
Thank you so much, Dr. Loeb, for covering in as much as you could in the time allowed this very, very important topic, and especially for leaving folks with many resources that they can use if they have more questions to discuss with their doctor and to find other sources of support and information. So we're about at the end of our time, but I think we have the time for just a couple of questions here. And Dr. Loeb, while I have you here, I know this has been a very important topic in the chat, and we got some of these questions before the webinar started. Returning to the question of sexual health and ED, what should patients consider if they see over-the-counter or natural supplements and remedies for ED, or maybe for decreased libido, and the decreased libido that might apply for Dr. Parikh's field as well?
So this is a very challenging question. So I would really be very wary of online information. We've had a whole bunch of studies looking at online information about prostate cancer in various networks: YouTube, Google, TikTok, Instagram, Pinterest, and found high levels of misinformation. And certainly supplements is one of the areas where there is a lot of misinformation. And the concern is that there's not a lot of regulation of these things. So a few years back, there was actually a study by Dr. Sharok Shariat where they observed some patients who took a particular men's health supplement and actually developed metastatic prostate cancer. And then they subsequently analyzed it in the lab and found, some concerning components. And so that particular supplement was taken off the market. But nevertheless, the quality control is difficult. And I would definitely recommend starting out with an expert in sexual medicine to explore options for pharmacologic therapy.
Absolutely, thank you. You shared that there are a number of alternatives, and folks should stay away from this information online that is not reliable. So this will also cover, I think, both Dr. Loeb and Dr. Parikh. We've had some questions about specific dietary measures that patients can use to improve their health if they are suffering from side effects, even specific, and this is for you, Dr. Parikh. Do you recommend patients cut out specific food groups like wheat or dairy or sugar, or what about the paleo diet in terms of the effects on the metabolism on ADT?
Yeah, it's an excellent question, and probably one of the top 5 questions that we get in clinic are right diets. And I think ultimately, the answer is that there's not a lot of great evidence around dietary strategies to help improve either prostate cancer related outcomes or decrease some of the potential events side effects from it. I think things that I usually recommend, and some of this is guided by published evidence as well, is given the significant risk of metabolic syndrome associated with androgen deprivation therapy in the patients that I treat, which are mostly high risk or advanced prostate cancer, avoiding foods or trying to cut down on foods that are high in saturated fats or high in sugar or carbohydrate content is always a good strategy, particularly for those men who have pre-existing either pre-diabetes or pre-existing cholesterol issues. Oftentimes we're only picking up on a diagnosis of pre-diabetes, so a state prior to the development of actual diagnosed diabetes based on a laboratory level. We're only picking up on that during their screening, that happens at the time that they're undergoing their prostate cancer. And so having to manage, making sure that we're managing that during the course of their prostate cancer treatment is really, really important. And I think trying to stay to a heart healthy diet, trying to stay to a diet that's important, that helps address a lot of the factors that are associated with metabolic syndrome, like diabetes and hypercholesterolemia or high lipids, is really important. I get a little nervous about the paleo diet. by sort of just kind of a blanket strategy of a low carb, high fat diet, just given that a high fat diet is sometimes really can contribute to a lot of issues in our population. So I would say that rather than that, sticking to a heart healthy diet, which there are many resources for online, is important. I oftentimes and nowadays have gotten our nutritional support team for people who are interested in tailoring dietary strategies to their own needs and cultural needs, needs within their communities. I often find that that is a really important resource, and particularly for you veterans out there receiving care at the VA, we have really robust nutrition resources that you can ask your doctor about and that are available for telephonic consultations. And I've been doing that a lot more with my patients.
Thank you, Dr. Parikh. I love that idea of specifically tailoring your diet with nutritionist and consulting an expert on that. Obviously, appointments can be packed, and so it's good to engage another resource for that. I think we have to leave it here. I'm just going to want to thank all of our panelists and our participants. It's been a tremendous afternoon. We had so many questions that we weren't able to get to. Many of these are addressed in the PCF Prostate Cancer Patient Guide. So please go to pcf.org/guides to get a free copy or request a free copy mailed to your home. And I'd also like to once again thank our sponsor, AstraZeneca, for making this event possible. Thank you, Rebecca. Thank you, Dr. Loeb and Dr. Parikh. And we appreciate everyone who spent some time with us this afternoon. Take good care and be well.
Thank you.
Bye-bye.